our members for improved outcomes. Let's take a moment to talk about this. So, we spend also, quite a bit of time on our telephonic outreach. So we get assignments from multiple of the Medicare Advantage members, and we use our customer service team to actually reach out to members who have not established care and that are new to the organization. You definitely have a blend of population, so it is a little bit more difficult to identify the members because you might have a member that's switching from one Medicare Advantage plan to another, but what we do is we outreach the ones that have not established care, and we help facilitate that for them. So we have a monthly list. So we do this on a monthly basis, and we have our customer service team outreach to the members and help them schedule an appointment. And if they haven't selected a PCP or if it wasn't identified in our eligibility file, then we help them do that and even take a next step to transfer them back to the health plan to make sure that it comes back on our next eligibility file. This definitely is a labor-intensive process. There comes times that, our overall customer service volume just can't manage it, but for the majority of part, we minimally do the reaching out, helping them establish a PCP and get scheduled with that primary care physician. We also do a lot of mailings. We're trying to transition that to more electronic, so it is a manual process today, and we're also, looking at ways of using our registry to make it a little bit better. But we're currently sending out annual letters to, first of all, our new member guide in general. So all new members get a guide and tell them how to reach us, how to establish care, all the different bells and whistles of our organization. But then we also reach out to any patient who hasn't been seen in the last 10 months. I know that sounds like a long time, but because we have the front-end process and the outreach telephonically, we wait for a good 10 months to make sure, are they homebound, are they not? But we wanted to make sure that they haven't come in for anything else. But if there's no activity, then we also send them for an annual letter just asking them to come to us and make an appointment if we haven't been able to reach them telephonically. The last thing that we do, and when we start this effort around March, is we establish relationship, and we use an APC, a nurse practitioner or PA, and we use a centralized scheduling team to reach out to members that are identified as our highest risk population and ask them to come in for this longer visit, being able to come in and get their care fully assessed from beginning to end, and that's worked really well. We partner with the PCP, and they come into the visit as well, the last maybe 5 or 10 minutes, so the patient knows that, this is one team, one unit. You're coming in. We have this overall assessment we want to do, and we want to, provide you with the quality of care that you deserve. And it's been really receptive. We've only done this for 3 months, and we did this for October, November, and December of last year. And we had positive remarks from every member that came in and was seen. And we really, our first, I want to say about 50 to 200 patients we saw were really, really high risk, and we're so thankful for being brought in.